Hello everyone, my name is Dr. Vernaya. Today we will cover chapter 7 for the first lecture of gerontology class. This lecture will be recorded into short, several 15 minutes lectures and will be named Part 1, Part 2, Part 3. Objectives for today's lecture. We will learn about the complexity of an older adult assessment. What are older adult needs? How different they are from younger individuals that we learn to take care of in clinical setting. We will learn also about environment adaptive devices and their effect on elder adult functioning. Also, we learn about the purpose of functional assessment and what is a functional assessment. The information that will be covered during today's lecture also are nursing roles related to function-focused assessment. Tools such as CATS, Lowton, SPICES will be used to evaluate activities of daily living and instrumental activities of daily living elder adults have. We also, at the end, will practice to create functional care plan. Usually in class, I do it as a group. I divide students into 3 or 4 together, because this functional assessment will be in your clinical setting, where you will do it individually. So you will have an opportunity to practice it all together and then individually in clinical setting. So what happens with human body as we age? Almost every single system of human body ages, including musculoskeletal, neurological, ear, eyes, respiratory, cardiac, gastrointestinal, genitourinary. So what specifically we will learn about different systems much later. But briefly, let's talk that, for example, with musculoskeletal system, there is a decrease in muscle mass, and joints become more stiff and less flexible. In conjunction, this can affect older individual capability to ambulate and to be safe, to prevent falls. In terms of neurological system, there is a slower conduction of impulses and information from one nerve cells to another. As a result, an elderly individual might need more time to comprehend, to learn information in comparison to younger individuals. Cardiovascular system, cardiac system, so this is conflicting opinions, but usually if a person does not have cardiac conditions, cardiac output should not be changed. But heart has slower response to stress, and you can see arterial stiffness as a result, increase in blood pressure, and increase in arterial size that causes arterial irritability and thickens endometrium. In terms of respiratory system, there is a less vital capacity and endurance, so individual ability to fight respiratory infection also decreases. With age, ability to taste food, same as a young individual, decreases. This affects appetite. Also decreases in food sensation, decrease in pH and loss of teeth, affects ability to enjoy food and digest food. With males with age, we can see BPH, and females might develop incontinence. It's not necessary that it can affect every individual, but every body is unique. Hearing and visual capacities also affect body functioning and safety. And finally, besides cosmetics changes with age, such as changes in pigmentation, balding, with age, human bodies might develop moles, and skin is less resilient, less able to fight the infection, and there is a decrease in elasticity. So today we will in detail discuss functional assessment. Functional assessment is a measurement of a person's ability to fulfill responsibilities and perform self-care tasks. What are these? It's basically what we do on a daily basis. We can take a shower, we can go shopping, cook meal for ourselves, and do some chores, cleaning within our home or apartment. So with age, things that is easy done by us can be compromised, and people who are older will need assistance. So with those who are all elderly, a functional status is used as an assessment and sensitive indicator for their health and illness. A decline in functional status might be gradual and might be seriously fast. Chronic or terminal illness might speed up the process of loss of functioning, as well as an acute illness. One of the most common manifestations of functional decline, as I told, is acute illness and medication, adverse medications. If you can recall when you had clinical rotations, CDERs at UCLA, how many medications a patient you took care was on? How long was the list? Did doctors review medication list? The more medications a person takes, the more risk of different adverse effects. I used to have a patient who was admitted, and she was like a vegetable. At the same time, a nurse who did admission, he was complaining that there are 4 pages of medications. So when I sit and start reviewing medications, good third of these were psychotropic medications. Some of them were from the same group, and I had to call my supervising and with the consultation of the doctor discontinue some of them. So the lady who looked like a vegetable, she was able to self-feed, she was able to help with dressing, with grooming. She's very smart, she likes to read, she can keep the conversation. Can you see the difference? Yes, she had stroke in the past and not able to ambulate as freely, but she doesn't need so significant assistance when she's not on the psychotropic meds. Other factors that also affect functional assessment is sensory capacity such as vision and hearing. So when we do evaluation of an elderly individual's health, we look how well they function, rather than we look at the disease alone. And their functional status has to be evaluated over time. So you do evaluation or as a baseline when you receive a patient, and then periodically after this. There is a little bit of statistics. Let's take a look. Elderly people who live in the community, so those who are not institutionalized, 25% of them have difficulty performing heavy housework. So cleaning, chores around the house should be done by somebody who are younger. 20% might have difficulty walking. So these individuals might need ambulatory devices, assistive devices, and you can see them walking around the street, around the city with a walker, a cane, but they still can live their life independent and with minimal assistance from other people. 10% have difficulty bathing, managing money, and using the phones. These people might have sensory deficiencies such as hearing and vision, and they might have developed dementia. And only 5% have difficulty dressing, using toilet, and eating. Why this percentage is so small? This can be explained that these individuals require 24/7 care, and not everybody can afford 24/7 caregiver at home. That's why these individuals might need to be placed in assisted living facility, boarding care facilities, and if 24/7 nursing care is needed, not a caregiver, then it is a nursing home. When we'll take a look at the nursing home environment, 70% of the residents require assistance with toileting and transfers from bed to wheelchair, from wheelchair to bed. 50% of these residents have bowel and bladder incontinence, 50%. And 40% so significantly debilitated that they require assistance with eating. Mortality, when we look at functional status, we use it as also independent predictor of mortality in elderly. And research was done, and we found out that dependency in at least one functional status can be a prediction in hospital mortality. Another study found that patients with cerebrovascular disease or pneumonia, the best predictor of in-hospital mortality was dependency index. In terms of hospitalization, hospital is not a good hotel. Everybody tries to stay away from hospital, and we try to manage patients as much as possible in outpatient setting unless it is not safe and we transfer patient to a hospital. An individual who gets into hospital becomes more dependent and needs time to recover. The older the individual, this process of recovery may take 2 to 3 times longer time than a younger adult. So even a common cold or influenza, a younger individual will need much shorter time to regain his or her previous health state. For an elderly individual, after hospitalization, who I received in a post-acute care setting, most frequently complaints like weakness in lower extremity. The person stopped and unable to ambulate at all or without significant assistance. So these patients need rehabilitation and physical therapy. At this point, they are not safe to go home. In comparison to a younger individual, when we use cure model with younger adults, we try to cure diseases, cure infection, for example. With older adults, we try to maximize their functional status, improve their quality of life to make sure that they can stay home independently as long as possible. In comparison when we deal with younger individuals. So when you take care of a geriatric patient, take a look at their abilities, what they can do, and encourage them to do this. For example, if an older adult after hospitalization unable to ambulate, but he or she is able to self-feed, give an opportunity to do this. Even if the process will take longer, the person will still perform this activity of daily living and will regain independence, at least in this area. And over time, physical therapy, occupational therapy can help with other deficiencies. Look at current needs and what care and support is necessary. Always do document. Make documentation at the baseline and then periodically your assessment afterwards. This will help you to see if progress happening or regress and something else is necessary. So it will help you to compare and evaluate. Overstate realistic goals. A person who is after motor vehicle incident and have fracture will not be able to attend dance club in a month or 2. So make your goals realistic. This will conclude the first 15 minutes of chapter 7. Please start reviewing chapter 7 part 2.